Hello, my name is Dr. Gordon Harper. In this section of the MOOC, I'm going to be discussing treatment planning. That is, how we convert the problems that people bring to us into a plan of care. People don't usually bring their children for help because of a diagnosis. Usually they come because they have a problem and they want help with the problem. How do we make a plan in response to that problem? Now, there's a great tendency in our contemporary world to believe that if we just know a categorical diagnosis, that is the kind of diagnosis we have in ICD and in DSM, and we know about evidence-based medicine, we're all set. Here, this slide represents this idea as a formula. The referring problem somehow produces a treatment plan or a plan of care. But what's in that box? There's several approaches that I'd like to discuss briefly. One is the use of categorical diagnoses. A second is what's called person-centered care. A third is the use of the multidisciplinary team. And the fourth is what has traditionally been called a formulation. Each of these has advantages. For instance, the categorical diagnosis has brought greatly increased specificity and reliability to diagnosis in child psychiatry as in the rest of psychiatry. The person-centered care approach has the great advantage of giving clearer expression to the voice of the youth and of the family, the parent, than happens when only professionally generated statements are used. The team approach has the great advantage of representing the efforts of a comprehensive team representing with members from several different disciplines, each helping the child in his or her own way. And of course, the formulation, as we've known for many years, has a great advantage of being developmental, inclusive, representing our best thinking about what's going on with the child. But each of them has a problem. Categorical diagnoses can produce a rather reductionistic, oversimplified view of what's going on. The person-centered care may capture the youth's perspective, but as often used, it loses the professional perspective and professional expertise which the child needs. The team approach too often becomes a multidisciplinary, not an interdisciplinary effort, in which the efforts of each discipline are not integrated or coordinated with each other. And finally, the problem with the formulation is that it may represent very good thinking and thoughtful caring about the child, but it doesn't easily translate into an operational plan of what to do. Let's think about each of these approaches. First, the categorical diagnoses. As stated, these are good for research, for epidemiology, and for administration, sometimes for treatment, but by themselves they do not guide treatment. For instance, even with a simple case, like a hyperactive child with a diagnosis of ADHD, psychosocial and medication treatment, we still have to know the child, the parent, and the school. As Sir William Osler said a century ago, it is much more important to know what sort of a patient has a disease than what sort of a disease the patient has. This is even more so when the case is not so simple. Then the categorical diagnoses fall short, as illustrated here. You can see discharge diagnoses like this on a patient summary: PTSD, complex, mood disorder, not otherwise specified, history of ADHD, and reactive attachment disorder. All those may be true, but look what doesn't appear in the summary. The fact that the youth has gender dysphoria and is at an early stage of transition. The fact that home instability is marked, among other things, by great disagreements about the gender dysphoria. The fact that the youth may have a history of hearing voices reported but not observed, and the possibility that some may raise that some of the assaults are so-called instrumental violence, that is, purposeful attacks on other people. Because these aspects of the case don't meet the criteria for categorical diagnoses, they're left out. Now consider person-centered care. What's a youth's future vision? Well, here's the kind of statement you might hear. Gina wants to be a rock star and live with her mother, whom she hasn't seen for years. The problem is, that's not enough. How do we integrate the youth's wish with professional experience and perspective? Now, what about a care plan that's developed by the multidisciplinary team, in which each member of the team is doing his or her own thing? This slide rather busy slide, but it represents the kind of comments that you can hear in a care planning meeting with each member of the team speaking up. If you try to summarize what's going on in the slide before, you see that psychiatry is diagnosing and prescribing meds. Nursing is supporting the child's daily living activities and teaching about healthy choices. The social worker is supporting the youth in his relationships with peers and with family visits. The psychologist is working on evidence-based treatments and coping skills, and the occupational therapist is doing sensory training with the youth and helping the youth participate in groups. In this kind of discussion, categorical diagnoses either do not appear at all or are given only to satisfy the requirement, it's a requirement to get paid, or they're used mechanically. Now the formulation is illustrated by this statement. Bill comes from a military family on his mother's side, so he has moved a lot. Reports indicate sexual abuse by a grandfather when he was 4 or 5. He's sensitive to tone of voice. He's working on identifying triggers. He shuts down when something is mentioned. But how do we translate this very thoughtful summary of the youth into an operational plan? We still don't know what's in the black box. Perhaps in the box there's a deep structure that guides treatment planning. These parts fit together as illustrated on this slide. All these disparate elements contribute to a central task, a central process that we'll try to illustrate now in the center. How do we get a plan out of all the pieces? Well, it turns out that experienced clinicians often have an implicit idea of how to translate all these elements into a plan, but it's often not made explicit. Here we're going to try to make it explicit, reducing the central task to a series of questions. Who is this person, including the child's strengths and challenges? What is a life vision for such a person? What problem gets in the way now requiring this level of care? That's the focal problem. What's the corresponding goal? What factors do we identify that keep the problem going that we can change? And what can we do for each of these factors? Those interventions make up the plan. This approach has advantages over the other approaches mentioned. The question, who is the person, starts out from a positive point of view, not just a deficit-based summary of what's wrong with the child. The life vision, the statement about recovery and getting on with life, can give hope. The focal problem reflects the fact that people don't come for a diagnosis, they come for a problem. The goal, correspondingly, is short-term, helping the youth get on with life. The factors are drawn from an inclusive, comprehensive understanding of what's going on with the child, and the interventions are very specific and operational. Each step in the process is owned by all members of the team, increasingly by the youth and the parent. This approach, including the definitions of who is the person, the future vision, and so on, will be shown in part 2 of this MOOC presentation. What we're demonstrating here is how we make a plan out of the problems that parents and children bring to us. Here's the figure we used in part 1 showing all the contributing pieces of information we have around the central figure. And we're going to spell out now what goes in there. These are the elements of the treatment plan, starting with defining a person, defining a future vision for that person, defining a focal problem and goal, identifying contributing factors, and selecting interventions based on those factors. That constitutes the treatment plan. Here the steps are listed as in part 1 of this MOOC. Who is this person, including strengths and challenges? What is a life vision for a person with such strengths and challenges? What gets in the way now, requiring this level of care? That's what we call the focal problem. What's a corresponding goal? What factors keep the problem going, and factors that we can do something about, and what interventions go with each factor? Here we are one by one. Who is the person? Strengths and challenges. What kind of life vision corresponds? What's the problem currently that keeps the person from moving ahead with his or her life? What's the corresponding goal? What are the factors contributing, stated in terms of adaptation and recovery? And finally, what are the interventions that correspond to those factors? At each point, we try to push for consensus, explicit consensus, about the nature of the problem, using language that belongs to everyone, not just to one discipline, and especially that gives voice to patient and parent. First, who is this person? We list the age, the gender, relevant demographics, background, strengths, and challenges. For instance, Pierre is a 15-year-old youth from Paris, parents from North Africa, likable and popular, with type 1 diabetes since age 8, seems smart, but with a long history of academic frustrations at school. The future vision spells out how people with this person's strengths and challenges live their lives. This takes a knowledge of how people with similar challenges live and grow, of their strengths and the relevant adaptive processes, not just pathology. For example, we might say, Pierre wants to be an engineer, but it's not clear his academic profile fits. Otherwise, he likes working with cars. The focal problem and the goal are what gets in the way right now of the future vision, has got the youth off track, and leads to seeking treatment. The goal represents enough change in that problem so the youth can get back on track. The focal problem is the real reason the child is at this level of care, not an inference, not a diagnosis. It's stated in language everyone can agree on, stated empathically, and it tries to capture the voice of patient and family. It may include, but it's not limited to, categorical diagnoses. For example, here's an illustration. Alicia, a 15-year-old Dominican-American girl, is brought reluctantly by her single mother, saying, "She's out of control. Her boyfriend is 19. He's not even Catholic. She's bipolar. I know it. I saw it on TV. Give her some medicine. Make her different. I want my girl back." The girl says, "Go to hell. I won't take any medicine." In this case, talking with both parties together, we came up with a statement they could agree on. Repeated severe arguments, sometimes leading to running from home, between a 15-year-old girl and her mother, with disagreement about expectations and about what is wrong. After discussing this, Alicia and her mother began to be able to talk with each other. The goal is the other side of the focal problem. What must happen for the child to live and grow based on an explicit statement of the future vision and recovery and adaptation. If there's no consensus, we work again on the statement. The word goal evokes many different meanings among those in our field. Some would say the goal is to understand better Johnny's problem. Another, more ambitious statement might be the goal is that Johnny's inner conflict will be healed. Another behaviorally stated goal might be Johnny will speak at school. Another, more ecological statement would be the school will accept that Johnny does not speak. In this case, as a goal we stated, decreased arguments, no more running from home, with Alicia and her mother agreeing about how to work with each other on their expectations. Now we try to make a list of contributing factors. The contributing factors reflect our best understanding of what keeps the focal problem going. They answer the question, what leads to this problem? What keeps it going? Not what is the problem? They operate in the present. They should lead to intervention. We can describe them in multiple domains in the child's life. They evoke normal adaptive processes, we'll speak about in a minute, and they're balanced by a list of strengths. All in all, we try to use them to give voice to the patient and family. For instance, not in this case, but in other cases, we would say the contributing factors are gets manic breakdowns, as likely a bipolar diagnosis, or doesn't take medication consistently, or is at an early stage of accepting chronic illness. A partner is intermittently supportive. The team is divided about goals. When we speak of adaptive processes, what do we mean? Well, adaptive processes are an alternative to talking about pathology. They're close to experience. They arise from real life. Asking about them fosters reflection and also fosters self-esteem. We talk about adaptive processes throughout the life cycle. For instance, newborns adjust to extrauterine life. Teenagers adjust to adolescence. After an injury, wound healing occurs. Children start school, there's a process of adjusting to school. After a death or other life event, a process of grieving. In substance use, we talk about the process of getting into recovery, and for those who've suffered trauma or molestation, we talk about a process of healing. Here's some examples of how we talk about adaptive processes all the time. A family gets together after a period of separation. A child or parent grieves for a lost special closeness. A parent helps a handicapped child develop, or a child with serious emotional disturbance. An immigrant family is in the process of acculturation, or a family lives with allegations of sexual abuse. Other families might be in the process of recovering from, child might be in the process of recovering from out-of-home placements, or living with the possibility of domestic violence. In this case, we talked about adaptive processes like this. Alicia is in a rocky phase of adolescent separation. We have to rule out a serious mood disorder like bipolar disorder. Also, rule out an unrecognized learning or language problem. The mother is isolated and scared. She feels a long way from home. The father has little contact with the family. And the professionals are divided, but focus mostly on whether to give medicine or not. In any factor list, we should ask questions like these. Do these factors reflect our best understanding of what contributes to the focal problem? And do they reflect a positive developmental view of the child? Once the factors are identified, we choose those in which we can make a difference. We choose an intervention corresponding to each. These interventions are the treatment plan. For example, in this case, for the factor of a turbulent adolescence, the intervention is the girl will meet with a child psychiatrist regarding her goals and how she's coping. Regarding the possibility of mood disorder or language disorder, the child psychiatrist will make an assessment. With regard to the isolated mother, the mother will attend a group with other Latina parents and meet with a parent partner. As to the estranged father, the child psychiatrist will try to contact him. And as to the narrow focus of the professionals, the girl will find a therapist social worker who gets it and start meeting with her. In this kind of plan, categorical diagnoses may be used as needed. To sum up and to look ahead, treatment planning is not assessment, much more than assessment. It's much more than a DSM diagnosis. And it's not just a list of interventions by team members. Hopefully it gets us thinking and is fun. Thanks very much.